Rob did his medical school at Harvard Medical School. He did an EM/IM residency at UCLA and then did his critical care fellowship at Stanford and has been on faculty at UCSF. He also, along with John Greenwood and Peter W. and myself, are co-hosting that CCPEM podcast that you all now have free access to for the next few weeks. Rob is going to talk to us today about updates in the ventilated COVID-19 patient, undoubtedly something that we have all encountered across our spectrums and our regions over the last 3 to 4 months. So, Rob, take things over and bring us home for this last discussion on our critical care symposium this morning. Thanks for joining us.
Thanks, Mike. Speaking to you from foggy San Francisco. And I want to start by thanking Mike Winters and the whole crew out there at University of Maryland. You have a phenomenal group and a phenomenal conference every year. I've treasured my association and collaborations with your group over the past decade. I guess it's more than a decade now. And I'm so happy to be speaking with you today. So we're going to talk about mechanical ventilation in the COVID era. And as you know, these past few months have been truly unique times. There have been dramatic changes in all parts of life and especially in healthcare. And the changes have been especially pronounced in terms of healthcare in the emergency department and in the ICU, as we are on the front lines of care for these patients. And so what we're going to talk about is we're going to try and make sense of one aspect of the care of COVID patients, and that's the mechanical ventilation of COVID patients. So I have no conflicts of interest to disclose, and so hard to believe that this COVID pandemic just started a few months ago. But within the past few months, there have been a surge of publications, a ton of research going on. In fact, I just did a search and there were over 40,000 medical publications about COVID as of this past week, which is an astounding amount of literature. It becomes so voluminous that it's really hard to sift through it all. It really becomes basically kind of overwhelming. There is this phenomenon of preprint studies, which I'm sure many of you have heard about, in which publications, in which articles are submitted in and deposited into one of these repositories. These are studies that have not been, manuscripts that have not been peer reviewed, but we are getting a lot of information from those, and I am going to include a couple of those in my talk. And again, so it's there's a ton of research going on. It's really a very, investigators have really stepped up to the plate to try and make sense of this new COVID disease. And here are, that you will have on your slides, are a couple of links to websites that have the repositories of those information. So my key messages in this talk are to keep using non-invasive ventilation, number one. Number two, COVID ventilation is very similar to ARDS ventilation, but there are some notable differences, and we're going to go through some of those. In terms of COVID ventilation, you really have to focus on hypoxia because that's the central issue with these patients. And then number four, we're going to go over the technique of proning. It's a huge benefit in these patients, both intubated and non-intubated patients, and we're going to discuss how to do those. Then the final message is I'm going to talk about the COVID ICU cocktail, which are therapeutics that should be considered for use in any critically ill COVID patient. All right, so we're going to start by reviewing some of the non-invasive ventilation modes. And this is pretty much background. And so there are essentially three modes. There's CPAP, which is basically PEEP. There's BiPAP, bi-level positive airway pressure. And then there's high flow. And traditionally, BiPAP has been the most commonly used of the three modes. It's great for COPD, as you know, and CHF. And in BiPAP, you separate the components. You separate the IPAP component, inspiratory support component, and then there's the EPAP component, which is basically just like PEEP. High flow has really come of age in the past 5 years, and it's really become very useful for patients who are just hypoxic and don't have true ventilatory issues. It's probably the mode of choice for those patients. In high flow, you set the flow rate, and you set the FiO2. And this has been shown to be better for kids, pediatric population, for patients who have altered mental status, because in those patients who have altered mental status, there's slightly less risk of high flow over BiPAP, slightly less risk of aspiration with that. And then it's also great in terms of, high flow is great in terms of palliative care, because it allows patients to continue to talk, continue to communicate much more so than you can with BiPAP. So a few words about how to make non-invasive ventilation work. It's all about really the first 20 minutes, the first 15 to 20 minutes with the patient. And typically in pre-COVID days, you would stand there with the patient, adjust the straps, hold the mask to the patient's face, adjust the levels of IPAP and EPAP to comfort, and most notably, you should think about sedation, using some sedation in patients who become claustrophobic or who may not be tolerating BiPAP initially. Now, when we're talking about sedation, you want to stay away from traditional benzodiazepines in these patients. Patients on BiPAP who get benzodiazepines often will have a paradoxical anxiety reaction. They'll often get more excitable and more uncomfortable than they were before. So the drug of choice really for these patients, first line, is ketamine. And when I'm talking about ketamine here, we're talking about low dose ketamine on the order of about 0.4 per kilo. So what I do for these patients is I have a syringe of about 100 milligrams of ketamine, and then I'll push about 30 milligrams to try and chill them out. And it works wonders. I'll push like 30 milligrams, see how it works. Success rate, my success rate with that low dose ketamine, I would say, is above 90%. It's really the drug of choice for these patients. And then you can just kind of titrate in boluses, or even sometimes give them an infusion of ketamine. Second line, I suppose, is fentanyl. In these patients, you can push like low dose fentanyl, about 25 to 50 micrograms at a time. The disadvantage with fentanyl is that it can suppress respiratory drive, and in some of these patients, you may want to maintain respiratory drive, and that's why ketamine is really the drug of choice in these cases. So initially there was a somewhat of a push or somewhat of a fear about using non-invasive ventilation in the COVID era. All of a sudden, there was this kind of a hold on non-invasive ventilation that we were seeing. People were afraid about aerosolizing the virus when approaching patients like that. But remember that even in sort of high prevalent COVID areas, many, if not most, of the respiratory distress patients that you're seeing in the ED are not COVID patients. They're your bread and butter CHF, COPD type patients. And so you really do not want to abandon use of non-invasive ventilation in those groups of patients, because they're the treatments of choice. So that's one reason to not give up on non-invasive ventilation in COVID patients. Again, most of the patients you're seeing are still going to be COVID negative, COPD, CHF patients. And even if it is a COVID patient, you really should still use non-invasive ventilation. You should give it a try in most cases. Again, there was a big fear about using that we're going to be contaminating the rooms, that we would be putting physicians, nurses, and especially respiratory therapists at risk with the use of non-invasive ventilation, but that really has not borne out. The latest research, and we at UCSF and are part of a big study looking at the risk of acquiring COVID in the ED. So far, knock on wood, it's been very low risk to be transmitted to providers in the emergency department. And so the things that you should, however, do if you're going to do non-invasive ventilation, you need to have that patient in a negative pressure room, and you need to use full PPE, and I would recommend PAPRs in these patients that you're going to use non-invasive ventilation. And there's a picture of a pretty stylish PAPR right there. Ours aren't quite that fancy. All right, another difference if you're going to use non-invasive ventilation in COVID patients is that you should use a non-vented mask system instead of the former systems that had that vented through holes in the mask. You're trying to render this non-invasive system into a somewhat closed system. And so again, you should use non-vented masks and a circuit that really kind of prevents expulsion of air into the room. So other COVID changes in terms of non-invasive ventilation are that perhaps you should favor high flow over BiPAP. Again, as we're going to get into, the primary pathophysiology in these patients is hypoxia, and not so much. They're not having so many difficulties with ventilation and elimination of CO2. So perhaps in these patients, we should be using high flow that addresses hypoxia pretty well. There's also theoretically a little bit less risk of aerosolization with high flow. If you're going to use BiPAP, you should consider using lower pressures instead of, let's say, 20 centimeters of water on your IPAP limb. You might cut it down to 15, and and you probably should not really get into super high inspiratory pressures with the BiPAP. Similarly, in terms of high flow, you probably should not get into the super high flow rates of 30 to 40 liters per minute. And we are at our institutions keeping the flow rate on the high flow to around 20 liters per minute, more or less. Another consideration is that if your patient is requiring more than 70% FiO2, you probably should just go ahead and intubate those patients. That's not an absolute, but the idea here is that COVID is not going to reverse very quickly. These COVID patients are, once they have the full-blown syndrome with severe hypoxia, it's going to take on the order of at least a week for them to get better, and often 2 weeks or more. And so if you're right away requiring that much oxygen, you should probably go ahead and move to intubation. And then a final note is, again, ketamine works great in these patients. I would continue to use that. It's the drug of choice. It's a wonderful way to kind of chill these patients out. All right, so now we're going to talk about the priorities for the intubated COVID patient. And your priorities for mechanical ventilation really stay the same. They're first and foremost, you want to oxygenate the patient. You want to maintain oxygenation. Second, the second priority is to avoid cardiovascular compromise. You don't want to be causing these patients to go into respiratory induced shock. You got to watch auto PEEP. You got to watch your pressures on the vent. You just really got to be careful overall with that. The third priority for these patients is to avoid further lung injury. And this really kind of goes with the second. You got to try and avoid further lung injury. In other words, you use small tidal volumes, ARDS type, ARDSNet type ventilatory parameters. And again, it's you want to avoid injuring the lung further. And then finally, not till the fourth priority, and I presented these in this particular order deliberately, not until the fourth priority do you really focus on ventilation and elimination of CO2. And this is especially true in COVID patients. As we're going to talk about a bit further, COVID patients aren't typically having a lot of problems in terms of ventilation, in terms of respiratory acidosis, in terms of elimination of CO2. And so it's not a particular, it hasn't been a particular concern, certainly not as much as oxygenation. All right, so we're going to review a bit about the pathophys of ARDS and why, and the reasons why we use certain parameters, ventilatory parameters in ARDS. And it's all really based on this open lung model, which really started in the 50s. And this is a hysteresis curve of the lung. And you can see here that it's a pressure volume curve. And what you're trying, and you can see, I don't know if you can see my pointer here, but on these areas of the curve, these lip areas, these extreme pointy areas out here, these are the areas of ventilation that you're trying to avoid. These are areas where you're getting a lot of pressure and very little volume change. And so you're not getting bang for your buck. You're not getting ventilation for your buck. And so what you wind up doing in these areas of the curve, these pointy areas at the end and at the beginning, you're transmitting a lot of energy. You're using a lot of force on the lung, and that injures the lung further. So what you're trying to do with, and really the underlying principle behind all of ARDS-NET ventilation is you're trying to keep the lung from snapping open and snapping closed. You're trying to ventilate in a sort of a narrow window where you have the lung opened up with PEEP, and then you're in a better part of this hysteresis curve where you're not transmitting a ton of pressure, and you are gaining opening of the airways and ventilation. So let's talk about COVID versus ARDS. And they're similar in a lot of ways. However, there are some significant differences between the two physiologies. First of all, in terms of the chest X-ray, the COVID chest X-ray, which is here on the bottom, the lower chest X-ray, it's similar to an ARDS chest X-ray. However, they tend to be a little plumper. They look a little fluffier, not quite as interstitial as most of the ARDS chest X-rays. But they both tend to have symmetric interstitial components. And so the chest X-rays are somewhat similar. The other similarity is that COVID patients have severe hypoxia. That is the most notable problem in COVID ventilation in COVID patients. Their pathophysiology is one of severe hypoxia. People have talked about how they come in and they look pretty good, but then you check their O2 sat and their sats are in the 60s and the 70s, and they're the so-called happy hypoxic patients. It is pretty striking. I don't know how many of you have seen these patients come in, but it is very striking how good they look and are so hypoxic. And that's really a testament to the fact that they're not really having problems with CO2 elimination. In other words, they're not typically huffing and puffing away. They're not they're not developing this severe respiratory acidosis, and don't typically have tripoding and Kussmaul rapid breathing. Another difference between COVID and ARDS is that COVID lungs, at least in the initial phase, they're not as stiff as you see with ARDS. The lung is much more compliant. Of course, later in the course, in maybe after a week or two, they do tend to start getting stiff. But at least initially, COVID patients are not highly stiff, and you don't typically run problems with high ventilatory pressures in these patients. These are advantages, distinct advantages of the COVID patient and of ventilating the COVID patient. And so, yeah, we'll talk a bit more about that in terms of our vent settings. All right, so in terms of the modes of ventilation in COVID patients, you really should not overthink it. They're really, you don't need to get too fancy. You don't need to start throwing in airway pressure release ventilation. It's just not, it's not really, you don't need to get fancy on these patients. You really should just stick to standard pressure control and volume control ventilation, and focus on the settings. Focus on tailored settings, individualized settings. I'm gonna slide it into the room over here because I'm not sure if the chirping birds on the outside are, if anybody can hear all that, but so you're going to focus on the settings. All right. And in terms of vent settings, remember that it's not a one size fits all type of thing. You really should try and tailor your vent settings to the particular scenario that you're treating. And so let's go over the various settings. Tidal volume, you are going to use standard ARDSNet type ventilation, 6 to 8 cc's per kilo. But remember that we consistently overestimate the tidal volume in shorter people. In other words, it's based on the kilo portion of the equation is based on ideal body weight, not true body weight. And ideal body weight is based on largely on height and gender. And so again, we consistently overestimate tidal volume for short people. Sort of general rules of thumb are that for a woman, for an average sized woman, I use around 300 cc's or 300 cc's. And for an average man, about 350 to 400. And if you really want to get meticulous and do it correctly, some places have tape measures. We used to have tape measures at our at the bedside and measure the patient directly. In terms of PEEP, in COVID patients, as you know, as mentioned before, hypoxia is a big issue for these patients. And so you are going to want to use high PEEP. I would say perhaps not quite as high as you would use in ARDS. We're talking about, PEEPs in the 14 to maybe 20 to 22 range, as opposed to PEEPs in the 18 to 25 range that you might use in ARDS. But again, this is going to be a trial and error type thing. You should probably start off with at least 14 of PEEP, and then titrate up or down depending on the response to that. One other point about this is that PEEP is best for diffuse symmetric lung disease, and it's classically, again, best for ARDS, diffuse pulmonary contusion. It's even great for CHF, which is diffuse and symmetric. It's not so good, however, for differential lung disease. For patients that have patchy one-sided pneumonia, it's not great. You can actually make things worse. You can worsen VQ mismatch in these patients who have, if you apply too much PEEP to a patient that has unilateral disease. And so in terms of tailoring your PEEP to COVID patients, there are some COVID patients that have predominantly unilateral disease. It's not always going to be symmetric and diffuse. So if you do have a COVID patient on the vent that has predominantly unilateral or patchy disease, you might consider a little bit lower PEEP in these patients. All right, what about the other settings? In terms of rate, as we talked about, we're not requiring typically very high rates for these patients. We're not running into difficulties with elimination of CO2, and you don't need these massive minute ventilations for these patients. So standard rates, typically maybe 14 to 24, and adjust according to your blood gas. But again, typically CO2 elimination has not been a big issue. Now, in terms of FiO2, this is the issue with patients. Oxygenation is the primary problem with COVID patients. And while you do need to oxygenate these patients, and you do need to keep them above a certain SAT, I would strongly recommend against superoxia. And what I mean by superoxia is like PO2s above 100, basically, on your blood gas. There's no need for that, and there's a lot of evidence that in other settings, in critically ill patients, that superoxic levels induce lung injury, they induce brain injury. They've been associated with poorer outcomes post cardiac arrest, post MI, and in a number of other critical care settings. So what do? Really, you should just start low and titrate to around 92 to 96%. I don't really, there's no need to have them consistently at 99, 100% oxygen on the monitor. And if you're having that, then you should really titrate down your FiO2. All right, so we're going to move on to the topic of proning. And this is another central theme of this talk. And we're going to start by why we do it. So why do we prone? So essentially all intubated patients who are supine develop dependent atelectasis after like a day. If you were to wheel your standard ICU patients on the vent down to CT, let's say you had 20 ICU patients and you send them all down for a chest CT, 19 of them are going to have dependent atelectasis. This is just really, it's a standard phenomenon that results. And so proning, and this dependent atelectasis interferes with oxygenation. It makes, causes collapsed alveoli. You get worsening of DQ mismatch and ultimately worsening of hypoxia. So proning is the treatment of choice for COVID patients, and for, I would say it's one of the treatments of choice for any hypoxic ventilated patient who's going to be on the vent for a period of time, virtually any of them. Then there have been trials, including the Proseva trial in 2013, which showed improved mortality with proning regimens in patients with ARDS. And so what does proning do? Proning basically reverses this atelectasis. It recruits dependent atelectatic alveoli. It improves flow to these ventilated areas that were formerly not ventilated. And it improves DQ mismatch. It does everything you want it to do. And so when you think about it, when you think about like what we do to patients when we put them in the ICU, and what we do to, you know, patients in general. We have them supine. You know, we transform a patient from into an unnatural state of just chronically being supine. And so, of course, they're going to get atelectasis. Of course, this is going to be a problem. And proning and other measures like this are simply a homeostatic way to try and improve what you reverse what you do with keeping patients supine. So the message again is to prone COVID patients. And when you do it early and often. As soon as we have a patient on the COVID patient on the vent, and their FiO2 is above, they're requiring an FiO2 above 70%, or even lower than that sometimes, we institute our proning protocol. Remember that, you know, it is not easy to actually prone a patient. It requires at least 4, typically 5 people to turn the patient over safely. And so you're going to want to paralyze these patients. You just don't. You do not want them waking up and reaching for the tube or dislodging the tube while they're prone. That's a recipe for disaster. So we typically prone our patients, schedule our proning around nursing change time. And so we typically do it at like 6 p.m. And 8 a.m. So we keep our patients prone for about 14 hours typically. All right, so what about the non-intubated patient? What about the patient that has that is not intubated but is hypoxic? Well, you know, this is a great idea. I mean, and this is one of the I would say positive or interesting phenomena that has occurred with the COVID pandemic. We're coming up with newer ideas. I really hadn't heard of self-proning until the COVID pandemic. I know that, you know, that it was maybe rarely used in certain circumstances, but now self-proning has become a thing, and it's you know, and it makes sense. The principle here, the difference between this self-proning in the non-intubated patient and proning in the intubated patient is that this is really more preventative. This is really an effort to prevent that dependent atelectasis. And so again, what you're trying to do here is you're trying to avoid keeping a patient supine all the time and prevent them from getting this dependent atelectasis. It's so intuitive. It's just so logical that, you know, I'm sort of surprised that it hadn't come into fashion, or it hadn't come into real play until this pandemic started. So there have been limited trials looking at this, but all of the trials have shown promise of this technique of non-intubated self-proning patients. They found consistently the trials have shown modest improvements in oxygenation and decreased intubation rates in those who can tolerate it. And that's kind of the key point, is that it has to be, the patient has to tolerate it. It's not very comfortable for a lot of patients, lying on their stomach with a mask for a certain number of hours is not, it's not very comfortable. And some patients simply do not tolerate it. But the bottom line is that it's very low risk, and it can improve the situation. So highly recommended, really should be standard of care. How do you do it? You know, it's really a nursing and patient-driven thing. You have to move you obviously have to move the ECG and other monitors to, you know, to keep them from being smashed or dislodged. You got to give the patient some padding and pillow. We give them a simple sheet. We hand them a sheet like this, a leaflet, and go over it with them, have the nurse go over it with them. And you know, it's sort of really patient driven. So you tell the patient to roll over to various positions. It's not, by the way, self-proning is not just prone and supine. It's really more of a kind of like a rotation. It's if you can sort of imagine just like on a slow moving baster, you're trying to rotate into different positions. You'll put them in the left lateral decubitus position, the right lateral decubitus position. But each time you need to do it for, each position needs to be for a minimum of about 2 hours. And it's important to closely observe these patients for the first 30 minutes to make sure that they're tolerating it and that they're not having desaturation. And you also got to look for pressure points and ulcers and problems with that. And again, so we give them this sheet, we go through it with them, explain it to them, and you know, it works out very well. Surprisingly, that, you know, a lot of the patients are really into it. What are the exclusions for self-proning? Well, there are a fair number of exclusions, but actually they're not, you know, I would say the majority of patients can prone. So some of the exclusions include chronic lung disease and CHF. And here they're really just, it's not that chronic lung disease or CHF is a history of CHF it's not that it's an absolute contraindication. It's more that if the physiology is truly CHF, or if the physiology in the patient is truly COPD, really proning is not going to help, and it might actually make things worse. So that's the reason that's an exclusion. Patients who have chest tubes, you're not going to be able to prone. Spinal instability, anybody who has like a spinal fracture or anything like that. The main one really has to do with GCS and altered mental status. The patient has to cooperate, and as I said before, this is largely patient-driven, a largely patient-driven thing. So they have to be able to cooperate. They have to be able to. You can't have an altered patient, you know, trying to do this. They also have to be hemodynamically stable. And most COVID patients early on have been pretty hemodynamically stable. Can't be pregnant, can't be morbidly obese. And, you know, the bottom line is that you have to the patient has to be able to call for help. In other words, they're going to be, they have to be able to sort of like hit the alarm button, or, you know, ask the nurse for help. And, you know, this is going to be a largely visualized thing. You're going to watch the patient from the door outside the room, you know, while they do this. And you know, and you keep it, it's pretty easy actually. You just need to keep an eye on them. With regard to the morbid obesity thing, exclusion, it's not a complete contraindication. And in morbidly obese patients, what you can do is you can kind of do some modified proning. You can like have them go to one side for a couple of hours. You can have them, you know, do just change body position and things like that. It's just difficult if they have a very large abdomen. It's difficult to you know, to really get a true proning procedure. All right. So we're moving back to the ventilated, the intubated patient with COVID. We're going to talk a little bit about neuromuscular blockade and paralysis. And really, there's no difference here in terms of when you should use paralysis in these patients. You have the same indications as you would in your ARDS patient. If the patient is dysynchronous from the vent, with the vent, and is and you're having difficulty ventilating them, you're going to want to paralyze them. Severely hypoxic patients, you're going to want to paralyze them. Of course, you're going to want to use twitch monitoring and your standard care for the patient in that way. And then, you know, as mentioned before, there's that special consideration. If you're going to prone the patient, you really should paralyze them. Again, you do not want them waking up prone and you know, and dislodging, or you know, moving and dislodging their ET tube while they're prone. All right. So we're going to move on to talk a little bit about some other agents that we use for hypoxia. And these are agents that are delivered through the vent, or even can be high flow in a non-intubated patient. And these agents are epoprostenol and nitric oxide. So epoprostenol is Flolan, and nitric oxide. These are pulmonary artery vasodilators, and they're great. These agents work really well for hypoxic patients and for COVID patients who are hypoxic. What they do is they improve DQ mismatch and thereby improve perfusion to well-ventilated areas of the lung, and therefore they improve the hypoxia situation. And you'll get about, you know, an improvement of about 10 to 20 PO2 on with these techniques, and they'll typically that'll be sustained for at least a few days. Eventually, you do get a tolerance from these agents, and such that they don't work as well anymore. But you know, they'll certainly buy you a few days of improved oxygenation. One pearl, however, is that we've been seeing is that you gotta watch for clogging of the vent filter with epoprostenol. We've had a few cases where the vent just kind of shuts off because the filter gets clogged. So you need to have your RTs keep an eye on that. All right, so moving on to ECMO. It's kind of, you know, it's always thought of as a last sort of for patients with severe hypoxia.
Yeah, how many times do you have ECMO therapy?
And so it's thought of as a last resort, but you really should not think of it as a last resort. If you're gonna use ECMO, you need to be prepared, and you need to you know, you need to have a plan, because it's not like you can just suddenly, I mean, most places don't have ECMO. So you're going to need to anticipate, you know, a day or two, at least a day or two ahead of time, whether you think a patient is on the trajectory to need ECMO. There's limited experience in COVID patients, but there certainly have been a number of case reports about patients improving with ECMO on COVID and surviving that way. The best data is from flu epidemics that standard flu epidemics, and there was a notable series of cases in Australia in which they found much improved outcomes in patients who had ECMO for severe influenza. ECMO is a treatment option approved by the FDA and by NIH, and there here is a guideline for its use. There's a link there that you can use to read more about it. All right, so I want to finish up with what I call the COVID ICU cocktail. What I mean by that is a regimen of therapeutic agents that really should be considered in virtually all of your critically ill COVID patients. These are, for now, and this is evolving. 2 weeks ago, this list was only 3, and now within the past 2 weeks, we've added the Dexamethasone component. So the COVID cocktail consists of Remdesivir, convalescent plasma, anticoagulation, and Dexamethasone. And these are agents, just like you have your sort of sepsis pathway kind of drugs, and you have your, you know, your ICU, standard ICU care pathways. These should be considered to be placed in a pathway for these patients with COVID. They should be protocolized and for consideration, at least, in all sick patients. So starting with Remdesivir. Remdesivir is a broad-spectrum antiviral. It inhibits viral RNA polymerases. It's been tried in a few different for a few different viruses. Most notably, worked for MERS. It was also tried in Ebola. It did not really help there, but it was successful in MERS. And this was really the first agent that showed improved outcomes in a real trial, and that came out in New England Journal about a month ago or so. Maybe even longer. It might be 6 weeks now. And what they found was that it shortened time to recovery for critically ill COVID patients. It almost halved the time to recovery from 10 days to 5 days. And there were trends toward improved mortality, 7.1% versus 11.9%. It barely missed statistical significance. If they had had a couple hundred more patients in the study, it almost certainly would have met statistical significance for improved mortality. The second drug in the COVID cocktail is plasma, convalescent plasma, and this is an old therapy. It goes back quite a long time. And the idea here is that antibodies developed by from a donor who has had and recovered from COVID can help a patient who has newly acquired COVID. And this is it's pretty easy to get. I mean, pretty easy to give. It's a single dose type thing. There are very few side effects with it. I mean, there of course can be a transfusion reaction, but that's very, very rare. It's best, and this is the key point here, it's thought to be best if given early on, like early on in the disease, not at the, end stage scenario. And so, in fact, we are giving it to all of our admitted COVID patients. And we are going to be part of a trial, a new siren trial, actually, that's coming down that will be given, in which we will be giving plasma, a dose of plasma to patients that we are discharging from the ED. So convalescent plasma appears to be of benefit. It's probably best early on. It is currently, it's really only available as somewhat of an investigational agent, and it all comes from really this one source. It's kind of being run by the Mayo Clinic, and there's the link right there that you can use to get it. It's not like you can get it like immediately. So you need to either have it at your blood bank, or if your blood bank does not have it, it takes about a day to get it. All right, so another part of the cocktail is anticoagulation for COVID, and recognize that COVID induces a hypercoagulable state. Clotting is a big problem in these patients, and it's both macro and microvascular thrombosis that we're seeing. We're seeing patients that have pulmonary infarcts, pulmonary embolisms, cerebral infarct, strokes, and even like COVID toe sort of extremity thrombosis phenomenon. And so here really is an opportunity to intervene. And when we're talking about anticoagulation here, we're not talking about full dose anticoagulation. We're talking about somewhere kind of halfway in between DVT prophylaxis and full DVT therapy or full PE therapy. So we're talking about doses of about 30 to 40 of enoxaparin BID. Lastly, the last part of the COVID cocktail is dexamethasone. And COVID, again, induces, another problem with COVID is that it induces a hyperinflammatory state. And, this is a so-called cytokine storm. And this is results of a very new study. It's only in preprint. In other words, the study has not been peer reviewed, but it was a study out of England in which they gave 6 milligrams of dexamethasone Q-day to a variety of COVID patients. And they found a third lower mortality in patients that had that were ventilated on the vent with COVID. So right now, while we can't, without peer review, we can't completely say that this should be used, but I'm certainly have adopted this into my practice. That's pretty low dose dexamethasone, pretty low risk, 6 milligrams a day. It's obviously extremely cheap. And if it does indeed decrease mortality by even a fraction, I think it's worth it. Again, the benefit was only seen in ventilated patients. All right, so I want to wrap up with some final messages. And the first is don't give up on the elderly. There's this thought or this fear that once a patient's over 70 or 80 and gets COVID, that it's a death sentence. And that's not really true. I mean, there are many cases of patients that have done quite well, octogenarians. I had a 101-year-old Honduran woman who got COVID and did very, very well. She got off the vent, back to her, back to her family, and so don't give up on the elderly. Second, final message is, early on there was a real angst surrounding COVID, and it was palpable. We in the ED and in the ICU were very, we're nervous taking care of these patients, and I think it's important to recognize that anxiety and that recognize the effects on it on work and home life. We did a multi-center study, a survey study at 7 sites, and we have this paper coming out in Academic Emergency Medicine, in which we describe that phenomenon. We also describe found measures that ED providers thought would help mitigate their stress, and so that paper's coming out within the week. Then lastly, finally, this has been in a corollary of what I just said a minute ago. The pandemic, it's been chaotic and dramatic and anxiety provoking. I would encourage you, just as I have done, to consult with your friends, consult with your colleagues when you have questions. Mike and Peter and John, my colleagues on our podcast, I send them a text every, probably once every week or so, asking them a question about, what are you doing for this in COVID patients? What do you think about that? And I have found that to be extremely helpful to me. It has helped, help quell some of the anxiety in taking care of this new pandemic. And so I would encourage you to do the same. And in that vein, I'm always happy to consult by email, and I hope you encourage you to reach out.
Thanks, Rob. I think that's a very, very comprehensive review in terms of the critical care end of the spectrum of COVID patients with mechanical ventilation. That is going to do it here for this, our 7th annual University of Maryland Emergency Medicine Critical Care Symposium. I want to thank Dr. Brown and the department for allowing us to continue this every year on an annual basis. Doreen for all of her hard work in the weeks leading up and making sure you all got the link, got the slides. In terms of any follow-up, we can provide you with a post-symposium email summary with the things that we've talked about. Also to Dr. Bond for running the live stream and the Zoom link. That's an incredible effort getting here way early this morning to make sure this all happened. So thanks to Dr. Bond and all of you. Once again, over 2,500 of you tuning in from virtually every state in the U.S. and 69 countries across the world. We've talked about a whole lot this morning. We hope we've provided you with some pearls on caring for the critically ill patient, regardless of your setting. Just 2 other things. And our next educational offering, something to put as a hold on your calendar. We are in discussion and looking to do our next Crashing Patient Conference. Dr. Matu runs that, and this may be the 10th annual Crashing Patient Conference, so a very big celebration. We're thinking perhaps October 14th, so put that as a hold on your calendar, but more details to come as we solidify details and plans for Crashing Patient Conference. Finally, our thanks once again to all of you that are combating COVID. We certainly are not quite out of the woods yet. We have many more months to go, and we stand with you in this. And on behalf of the University of Maryland Department of Emergency Medicine, I thank you for your participation and interaction and viewing of our Critical Care Symposium.